me. And I'll share my screen here. Can you see that?
Can everybody see the slides? We'll make it a little bigger here. What I'm going to talk about today, thank you, Joy, for the introduction, and thank you for asking me to give this presentation. It's fun to be a part of this course, which has been such an important resource for many young physicians and other scientists to do clinical research in neurology. I am going to turn my video off for the time being. I'll put it back on when we get to the discussion. I have had a spinal cord injury so that I have some limited mobility. And so Joy is going to be in charge of the slides. And so I'll have her go to the next slide. So I have no conflicts of interest. Next slide. All right, the goal, what we're going to talk about today are some of the issues in the design of clinical trials in neurology and the importance of clinical measures, because these will be used in all types of neurologic research. And because my area of expertise and interest is stroke, I'm going to put most of the examples from stroke studies. Next slide. Now, I've been involved in the writing of guidelines, which are now the foundation of evidence-based medicine and actually the standards of care. When you write guidelines and when you participate in guideline writing, which all of you will, you'll find that the information included in the guidelines has largely come from modern clinical trials. Having been practicing neurology for 5 decades, I can tell you that the strength of evidence of clinical trials and the design of clinical trials now compared to 40 years ago is much different. Regulatory bodies such as the FDA and third-party payers such as insurance companies are influenced by the results of clinical trials. I had the experience of being on the FDA advisory panel 25 years ago when we approved TPA for treatment of acute ischemic stroke. It was approved largely on outcome measures that were clinical in origin, actually was the modified Rankin scale. We made that decision based on data that made sense. Next slide. So when we design clinical trials, we want to look at what the goal of the clinical trial is. This can be prevention, such as, for example, preventing recurrent stroke in people with TIAs, something that is slowing progression of the disease, such as a Parkinsonian trial, avoid recurrent events, prevent complications. This can be medical complications, psychological complications, cognitive impairments. We want to look at mortality. We want to see how recovery is maximized. And then we want to look at the quality of life of an individual. So there are many measures of outcomes that are going to be looked at in clinical trials. And depending on the primary hypothesis of the trial and its overall design, the type of outcome measures will be selected by the investigators. Next slide. So now, one of the problems in talking about clinical outcome measures in neurology is that we have a wide variety of diseases that fall under the rubric of neurology. They have different types of neurological problems. The epidemiology varies considerably. Comorbid diseases influence outcomes. We have best medical care, which becomes the control. And the treatment goals and the nature of the intervention may vary between clinical trials. Next slide. Now, when we organize a clinical trial, randomization is a crucial component. This avoids bias in recruitment, and I think all of you are familiar with randomization. Now, how do we select what measures we're going to use? for randomization. This is going to be involved with the history of the illness, the severity of the impairments, and maybe comorbid diseases. All of these are clinical criteria. Now, it's possible that some trials will have ancillary studies, such as size of lesion on MRI, or a level of white blood cell count in the CSF. But generally, these are going to be clinical criteria. Next slide. So we do have surrogate markers in neurology. We have imaging, we have functional studies, we have CSF biomarkers, we have genetic testing, we have electrophysiological studies. But I will tell you, you want to have a clinical outcome as the measure of success. A few years ago, we were involved in a large multinational clinical trial testing a factor 7 in treatment of patients with acute brain hemorrhage. The drug was successful in reducing the volume of growth of the brain hemorrhage, but overall the trial was negative because there was no change in clinical outcomes. So the surrogate marker was positive, but the clinical outcomes were negative. And the clinical outcomes, of course, were the key measure. So surrogate markers need to be able to follow the clinical markers that we're going to talk about. Next slide. Now, another component of clinical research is the blinding or masking of both the patients and the investigators. This will vary depending on the type of study. We have done very extensive double-blind trials, including trials of anticoagulants, where we produced surrogate prothrombin times or clotting factors from local monitors to keep the investigators unaware of which treatment arm the patient was in. So there are lots of ways you can maintain blinding or masking. Of course, another way is some independent panel, which may be involved, for example, in a large trial where it's just comparing medical and surgical interventions. Next slide. So let's go to the clinical rating instruments. These are a fundamental component of all clinical research trials. Now, some of them have become so widely used that they are also in clinical practice. Why do we use clinical outcome measures? One is eligibility for enrollment in the trial. We will give you some documentation of the types and severity of neurologic impairments. It can be used to monitor progression or improvement of neurological status. It may obviously influence decisions about management, responses to treatment, and then outcomes at some point in time, 24 hours, 3 weeks, a year, whatever the outcome of the trial is. Next slide. Now, what is the requirement for a useful clinical rating instrument? It has to have inherent credibility. If the rating instruments do not make sense to the public or to healthcare providers, the rating instrument is not very good. It has to be understandable. We should have an idea of what the patient's status is when given the score on the scale. A scale that has 100 points and you have favorable outcomes of 75 points in one arm and 72 in the other, those minor differences will not make sense to people who are reading your research project. So you want to have clear, well-defined rating instruments. And we're going to go over some and show how some of them work. Next slide. Now, when you develop a clinical rating instrument, and I've done this, it's a complex process. When we developed the NIH stroke scale, which I'm going to go over in a couple minutes, this took us about a year to come up with the scale itself. It has to be have a reason for why the scale is being used. It has to be relevant. It can be assessed by history, examination, or diagnostic studies, or some combination of the above. And you have to have decided how to test and validate the instrument. Next slide. So what is a useful clinical rating instrument? Now, if you want to go out and design a new rating instrument, more power to you. But you want to have an instrument that is easy for patients and assessors. There are clinical rating instruments that are really very difficult. Performance and scoring should be straightforward. You want clear instructions on how to use them and how to score the results. It has to be tested for reliability and reproducibility so that the same rater gives basically the same score every time, and the two raters assessing the same assessment will have similar scores. And for clinical research, there has to be an education and certification program. New slide. Now, for a clinical trial, there's even more steps that have to be put in. You want to know that if it's a multi-center trial, whether the scale is administered and scored correctly. You want to be able to use the scales scores in comparison to other research programs. And then you'll have to do projects, particularly with a multi-center trial, to educate and certify the raters, and if necessary, have central adjudication. For example, in the TOAST study, which I was the PI on, one of the things was determining the subtype of cause of ischemic stroke. It ended up that yours truly had to adjudicate all the subjects in the trial. Now, I was either consistently correct or consistently incorrect, but I was consistent. So we did not have 2 or 3 different people coming up with slightly different assessments. So it really requires considerable thought as you go through this. Let's go on to the next slide. Now, many young investigators have the desire to do a new clinical rating instrument. I would suggest that this is not where you should go. It's time consuming, and you may not be successful at the end. It will delay the primary goal of the project. So I would suggest you adopt or adapt current scales for use in your study. New slide. This is further buttressed by the comments from the NINDS, all of whom you are interested in, which have developed common data elements for standardizing research. This is a major advance in research of all clinical trials. They have lists of favorable data elements to examine for degenerative diseases, stroke, headache, trauma, and a variety of other neurological diseases. These are well standardized instruments that are widely used, and you can compare the results of your research with other clinical trials. So I would strongly urge you to look at the list of common data elements for your area of research and adapt one or more of them to your project. Next slide. Now, when we look at clinical rating instruments, some are based on history, most are based on direct examination. Please remember the differences between impairments, disability, and handicap. How I define differences between impairments and disability is if 2 people go out into the woods and each through accidents both lose their right hand. Both have the same impairment, but the one person who is a vocalist is not disabled or handicapped, while the pianist has obviously lost his ability to play the piano. So we need to know what the rating instruments are. Some scales will include results of diagnostic tests. Now, when we look at scales, we're going to find 2 basic organizations, and I'm going to go over a series of examples in the next several slides. There are numerical scales that add components of the assessment, each of which is rated. And then there's a single score scale, which puts all the information into an aggregate scale. An example of the numerical scale for those who are interested in stroke would be the NIH stroke scale. For the single score scale, example of stroke would be modified Rankin scale. Next slide. Now, in numerical scale, several items are assessed and scored. Then they are added together to give a total score. In some places, a high score is good, and others scales, a low score is good. The NIH stroke scale, for example, has a range of 0 to 42, with 0 being what everybody wants and a 42 not being so good. I describe the NIH stroke scale as being like golf. You want a low score. It's not like basketball. Next slide. So here is an example of a numerical scale, which is used in predicting outcomes in patients with atrial fibrillation. As you can see, it combines findings by history, such as diabetes mellitus or prior stroke. It includes its epidemiological factors such as age and whether a patient is male or female. And as you go through this, you can see that the higher the score, the higher the risk of embolic stroke. So this scale, for example, has become very important in selecting patients for clinical trials in atrial fibrillation. Next slide. Another numerical scale, which is widely used in trauma, is the Glasgow Coma scale. This is a scale that ranges from 3 to 15. And the higher the scale, the better the patient is. This is also used in patients with brain hemorrhage. Now, of interest is the score is, a minimum score is 3 and maximum score is 15. But as you look through here, you'll see that there's a real step down in prognosis as you go. This is used not only by researchers, but is used by emergency medical services. And most emergency medicine physicians have a good concept of what a patient is like when they have a Glasgow Coma scale score of 7 or 8. This has to be modified when it comes to verbal response in a patient who's intubated. Next slide. The ICH score is one that is now being done for assessment of patients with brain hemorrhage. This is an interesting scale in that it has clinical severity, it has imaging on CT, as well as some epidemiological factors. It has the Glasgow Coma scale that we just talked about. It has presence of intraventricular blood on CT, where the CT is located, and the patient's age. This scale is now mandated by groups such as the Joint Commission to look for how well a clinical service or a stroke center is assessing patients with brain hemorrhage. Next slide. Now, another numerical scale, which one is that I take pride in, is the NIH stroke scale. This scale was developed in collaboration with investigators at the University of Cincinnati, Tom Brott in particular, investigators at the University of Iowa, and investigators at NIH. Now, this scale has 15 items of the neurological exam, and it's used in patients with stroke. It can be done on entry to the hospital, can be used for subsequent assessments for worsening or improvement, or you can also use this as a long-term outcome measure. The higher the score, the more severe the stroke. Next slide. So here are the components of the NIH stroke scale. I think many of you are familiar with them. Anybody doing stroke research or doing clinical care in stroke is now required to have been certified in this. This is the most widely used scale in stroke research in the world. Next slide. Now, what did we do to validate it? And this is the sort of step that you have to take if you're going to validate any other scale for research in any aspect of neurology. We did inter-rater agreement and inter-rater reproducibility, so the scores came out basically the same. We also correlated it with the size of lesions and outcomes, and we tested it in several other venues. So this scale was gone through several steps to be approved and accepted by the medical community. And as I said earlier, is now accepted both for clinical trial in stroke, but also epidemiological and other research studies looking at patients with ischemic cerebral vascular disease. Next slide. Now I show you this slide from one of our research as to why it was so important. If you look at where the patients have a low NIH stroke scale, down there to 0 to 3, you can see the vast majority of these patients had an excellent outcome. Thus, enrollment of patients into a clinical trial that patients have a mean score of 3, you're setting a very high bar to show some major difference in treatment just based on outcome. Conversely, if you enroll patients that are in the range of 20 to 25, you can see that almost all those patients ended up with poor outcomes. And so once again, it's going to be hard to demonstrate a difference by an intervention. So clinical trials have often lopped off the patients that come in with under 5 on the NIH stroke scale because they know they're going to have a difficulty in determining a treatment response, and similarly the very severe patients. So the middle 3 of those, or a middle 4, will be the ones that are most likely to be recruited into clinical trials. Next slide. So in order to increase the reliabilities of these scales, we developed at Iowa, and then our colleagues at UCSD developed a reliability of the test of raters. So raters were asked to go to websites and score multiple patients who are on multiple videos to determine all components of the NIH stroke scale. This included education and testing, and in some cases retesting. We found out that the components of the scale that were least reliable were limb ataxia, which we'd put in for cerebellar lesions, and facial asymmetry, which was very hard, at least on the videos, to determine. They're still as in components of the NIH stroke scale, but we do recognize that some components are harder to trust than others. Next slide. Now, another outcome measure, and this is global, which is one against scoring from 0 to 100, with the 100 being complete independent, is the Barthel Index. This is a global outcome measure. It assesses degree of independence. This can be used in a broad range of neurologic diseases. Somebody who has a score of greater than 60, and you see the points are 5, 10, 0, 5, 10 for most components, is independent. And if somebody has a score of 90, they're usually considered a complete recovery. Now, some of these scales do not work very well depending on the type of neurologic disease. For example, a Barthel Index will not do well in assessment of a patient with a spinal cord injury, such as mine. Next slide. Now, one of the other, let's keep going. All right, so on the single scale, we're going to look at all components of the assessment and summarize them into a single score. Each score has specific and defined criteria. Generally, the higher the score, the poorer the situation, with 0 being complete recovery, and depending on the score, 5, 6, 10 being death. Next slide. So here is an example of a single score in acute treatment. This is the Hunt and Hess scale, which is a single scale for evaluating patients with ruptured aneurysms. It's based on clinical findings on admission and a poor prognosis with higher scores. and this has been widely used both in clinical research as well as in actual patient care. One of the advantages of the Hutton Hess scale is that our neurosurgical colleagues generally have a good feel for what each individual score means. Next slide. The Rankin scale is a global outcome scale that also is internationally accepted. This was developed in Britain back 40 years ago. It was modified, and that's where the word modified came in, to add additional score, including mortality. This is based on patient report. It has an emphasis on motor limitations in walking, and that is one of the weaknesses of the Rankin scale. But it can be performed by a broad spectrum of healthcare providers and can even be assessed over the phone. So there'll be different levels of recovery that both physicians, regulatory bodies, and even the public can understand. Next slide. So the modified Rankin scores, 0, which are no symptoms at all, which I think is a little too strict, down to minor symptoms all the way to 6 as being death. Most trials in stroke have cut the good versus the poor outcomes between 2 and 3. Some people will make it, depending on the type of patients, 3 and 4. But 4, 5, and obviously 6 are always considered poor outcomes. 0 and 1 are usually considered favorable outcomes. And depending on the type of disease and treatment modality, scores will range on 2 and 3. Next slide. Now, so one of the problems with global measures of outcome is that they require larger clinical trials. On the other hand, these scales are accepted by the medical community, funding organizations, and regulators. They generally separate good and poor outcomes. They can be used in both acute and recovery trials. They can also be used indirectly in trials that are halting progression. One of the problems is that this global outcome measure may miss important neurologic issues. For example, the issues with the Rankin scale is there's not a lot of scoring for things such as aphasia or cognitive impairments. And in addition, they may have ceiling and floor effects, where it's very easy to get to a minimum score, but maybe the top score may be hard to achieve. Next slide. So here's another example of the Rankin score for outcomes. There can be a direct comparison. And now popular one in stroke is a shift between the intervention and control, where if you look here, you see that the favorable outcomes 0, 1, 2 seem to be much better in the intervention than in the control. Next slide. Another outcome scale is the Glasgow outcome scale. Now, this originally was 5 items. It's been expanded to 9, and it's usually used for trauma, but it could be used for other severe brain diseases, such as stroke or brain tumors. Once again, you see the types of impairments that go along with this. Now, you would argue there may be a little vagueness to some of these definitions if you go over, dead is not so problematic, but if you look at lower good recovery and upper good recovery, it kind of becomes a bit amorphous as to where one is a 7 or an 8. Next slide. So another form of scales that you can use are to prevent or treat complications of neurologic disease. Remembering that neurologic diseases often lead to a number of other medical problems, such as pneumonia, or deep vein thrombosis, or falls, or malnutrition, or depression, or dementia. All of these are important measures that may be useful in assessment of an intervention to treat or prevent a neurologic illness. All right, let's go on to the next slide. So there are a variety of tests The two most common for cognitive impairments are the mini mental status and Montreal cognitive assessment. Probably the Montreal is used more widely now than the mini mental status. When I had my injury, having used this test on multiple patients myself, when they came in to assess me for the Montreal cognitive assessment, I kind of went through the things without looking at it. And I don't think they were very happy with me. All right, let's go on to the next slide. Another form of long-term outcome measure is quality of life. There are varieties of scales available with this. I've shown here is the EuroQoL, which looks at varieties of activity, mobility, self-care, feelings of anxiety or depression, etc., all of which become important in looking at how a person has recovered from a neurologic illness. Next slide. Now, in addition, there are modality-specific scales, which are used primarily in rehabilitation and recovery research. They will emphasize one component of the patient's neurological problems, such as walking or hand function or language. These do not generally provide an assessment of the patient's autonomy, but still may be very useful in determining how the patient's doing in one specific area. Next slide. Another type of scale is an ancillary scale, where you will look at how patients are responding by an imaging study, such as recanalization in patients with an acute ischemic stroke treated with endovascular therapy. And this can be used as an adjunct to the clinical outcome measures. Next slide. So there are a wide variety of instruments for clinical research in neurology. Depending on what your goal of your research is, it can be prevention, acute care, rehabilitation, long-term outcomes, etc. Some of these are going to be modality specific, while more commonly they will be global. No single clinical instrument will address all aspects of a patient's neurologic disease or treatment. Next slide. However, they do provide a quantitative element to a complex clinical situation. Knowing this is how you will compare patients in a variety of clinical research studies. Results of modern clinical research studies will have clinical rating instruments, both for eligibility and outcome, in the part of the design of the study. And I would encourage you to use these instruments in your research, because they will be important as you can share your data in moving forward. And I think that's the last slide. And I'm more than happy to try to answer questions.
Again, if you have questions, please use the chat box and/or Q&A feature at the bottom of your screen. Or you can ask to unmute and I can allow you to talk as well.
I'm sorry I did not go through a large number of scales that are not used in stroke, but there are going to be similar things that are going to be for all neurologic diseases. It may very well be for treatment of seizures. It will be frequency of seizures, complications of seizures, SUDEP, for example, or it may very well be overall patient integration into society. So there are a variety of scales that are available. You just need to pick the ones that are, if you can use.
So Dr. Adams, there was one in the Q&A. Says, Dr. Adams, you have advised against the development of new clinical rating scales. Do you have the same opinion in developing patient-reported scales/surveys?
Well, one of my concern is the more you develop, why I was saying against it is that you have finite time to get a research project up and going. I describe a clinical trial as kind of like getting a 747 off the runway. You don't want to attach a lot of things onto the wings of the 747, which will slow it down. And if you have 5 years to get a research project done, you don't want to spend a good year and a half trying to develop the scales. Secondly, if you come in with new scales that have not been validated, I will assure you the reviewers for the NIH or some other body are going to look at skepticism of the scale if it's not well known for a couple reasons. One is they will not know how it works. And secondly, they won't know how to compare your data with other clinical trials. As far as ones that are investigator administered, such as the NIH stroke scale, I see them as not being any more difficult to do than the patient-reported ones. I would be very careful about a patient-reported scale that has not been well validated. I've been on advisors to researchers who've been developing studies as part of this program, and I've seen the difficulty they've run into with patient-reported or observer-reported outcomes that have not been well defined. So I would not, I guess my concern about the scales is maybe even double for the patient-reported ones. I hope I didn't discourage you too much.
There's another question. How do you recommend determining whether there is a need to develop a new clinical rating outcome scale?
All right, well, that will depend on what the situation is going to be. Like I said earlier, I would be very careful about developing a new scale. It would have to be some reason that the current alternatives are problematic, such as poor inter-rater agreement or intra-rater reproducibility, that it not be really relevant to the outcome that you are seeking. So you'd really have to have a strong reason to move into a new scale. So you would, it would be very careful. Somebody has asked me what to validate an instrument. So what you have to do is, first of all, you have to define what you are rating. What part of the patient's clinical status? Is it a number of seizures, or is it a neurologic impairments, or whatever it is? Then you have to define what are going to be the scores that you're going to have. It could be A, B, C, D. The Asia scale for spinal cord injuries is an A, B, C, D, E score, which is backwards to me, because A is complete paralysis and E is excellent outcome. So then you have to have the components of what's going to have to get those various scores, and those have to be well defined. Then you need to take the scale and bring it to a clinical setting where you have a series of investigators collaborate and evaluate the scores on a patient. Now, this could be done by video, or it could be done by live interviews, etc. You want to see if Dr. A and Dr. B get basically the same score. A little variation is okay, but if it's one says a favorable outcome and one says an unfavorable outcome, you've got a problem. You then want to go out and test it on a larger number of researchers or investigators or coordinators or whoever's going to administer the scale. When you go out to a larger group, you have to have the definitions for the various components of the scale very well defined. Then you have to see if the raters can do the scale accurately. So it's a lot of steps. So if you're going to develop a new scale, This is not going to be an overnight exercise, but it's going to be a good year to year and a half to get it developed. Now, Gil Wolf asked about how we've done with scales. The NIH stroke scale obviously was first in English. What has been translated into almost every language in the world, like small language groups know, but I know it's into French, German, Spanish, Japanese, and Chinese. For example, there's a scale for there's a instrument on articulation where the words were picked that had difficulty as far as enunciation of different syllables. And so, but the right translation of that into other languages did not work. So we had to adapt some of the components to English. And those have worked really very well. Have they been impacted by cultural differences? Yes, they can, particularly some of the outcome scales where disability is rated. I don't want to sound like I'm being a nationalist here, but I will tell you what is the degree of neurologic impairments that may be considered disabled vary considerably around the world, with some of the European countries having much lower threshold for societal disability than some other parts of the world. So you have to adapt that. Yeah, so one is adapt to language, two is looking at a little bit of cultural things. Yes, those are both very important. We do have, in the United States, the NIH stroke scale has been translated into Spanish, French, and I'm not sure what other language here. I hope that answered the question.
You see that next one, Dr. Adams?
All right, just a second. All right, so especially given the COVID era, which I hope we're going to get out of very soon, are there particular resources where one can find clinical scales other than, say, NIH mentors, basic literature searches? Joy wants to answer this one, and I will let her do this.
Oh, no. I just want to dismiss it that you're answering it in person.
Okay. All right. Okay. So how does I don't know. I think you're going to have to go to NIH. You'll have to go to talk to your mentors. It probably is going back to looking in the area of research that you are doing to see what's in the literature as scales and review those scales with colleagues. Another thing to do is one of the advantages of this course is that you can bring up the various scales to the mentors that are part of this course. That's a real advantage of this program, and let them advise you. There have been some, depending on the scale, there's been some validation using videos. There's been validation with phones. I'm not sure about social media, but I know, for example, in one of the large trials testing a treatment for brain hemorrhage, all the patients at their outcomes were videotaped, and we did the exams, and the forms were all sent to a central area where they adjudicated the outcomes independently of how we rated it. This was an attempt to increase the validity of the scores. So yes, this stuff is being done in a variety of settings. And I'm sure there are more things that are going to continue to happen. I'm hoping that the COVID issue will be behind us soon enough that we don't have to worry about this anymore. All right, I hope I've answered the questions okay.
Can I ask another question, Dr. Adams?
Sure, Bill.
I want to thank you for the presentation, and I want to actually just offer one confession first. And this is one of the, I think, things that's sort of interesting in biomedicine and research. Despite having done a stroke fellowship, despite having performed many modified Rankin scores through validated and structured ways, I never fully understood what was modified about the modified Rankin. And I think one of the things that we learn is there's always something else to learn. And I really just thank you for enlightening us on this and all these topics. Maybe many other people knew that, but sometimes it's good to get back to the sort of facts and the history of these things. So the addition of mortality is just such a fundamental part of it. And I think something that I really like about the scale, but here I am, after pretty deep into my training, so to speak, and learning that. So that's just a blessing.
One of the things that's happened with some of the scales, for example, the NIH stroke scale, there have been attempts to modify it and take things out. And for example, the NIH stroke scale does not work well in children. So there have been attempts to try to change the scales. Those are all things that are in the literature. How good they are is another story. And there are new rating scales that come along. I didn't talk about differentiating subtypes of ischemic stroke using the TOAST criteria, which I have a special love for, or other research scales. But they're all these are available and can be looked at. One of the things is the more the differentiation into smaller groups. So a 100-point scale is going to be much harder to interpret clinically, and it's going to be much harder to use in an assessment program or certification program. So a finite number of outcomes with clear definitions of the outcomes, and those outcomes make sense to our colleagues, are the key to any outcome scale.
So the other part of my question, how do you respond? I think sometimes people, particularly in challenging conditions, let's say whether it's TBI or Alzheimer's, where there's been a really tough time developing effective treatments, maybe ALS, there's a sort of call for there to be better, quote unquote, better outcome measures. We need to develop new or better outcome measures. What do you usually say to that? And I guess the other sort of part of it is, clearly for some of these diseases that have been hard to develop treatments in, we need better ways, I guess, to help learn in the early space what things might be successful later, if possible. So I guess, how do you respond to people, particularly junior people or senior people, who want there to be new outcome measures because they feel they're unable to move the field forward with their current ones?
Well, the question is the intervention not effective because of the outcome measure used or because the therapy doesn't work? And probably most of the time it's the therapy doesn't work, and they're going to blame the outcome measure when in fact the therapy doesn't work. I'm all in favor of somebody developing a outcome measure that is superior, but if they're going to do it, they have to go through the various steps that we just talked about and make it useful. And you don't want to delay, particularly for junior people, delay their research project that's finite time by spending time in developing an outcome measure. I would still use caution. Having seen variety of outcome measures come through, it depends on what kind of setting that you're trying to do. So if they want to do a new outcome measure, fine, more power to them, and they'll have my blessings, and I hope they'll succeed.
Any other questions? Oh, one.
Yeah, Bill has got a hotline call, so he left us.
Yeah. Dr. Conwent has one. Do you see that one?
All right. So for the telemedicine ones, you can do the It's hard to do the NIH stroke scale completely by video, but it can be done. Of course, we've done it in telemedicine for enrollment of patients. So you can use the NIH stroke scale. The modified Rankin scale definitely can be done over telemedicine. It's worked very well. Some of the others, you could probably do the Barthel index over telemedicine, because once again, it's primarily history. Is the person able to go up and down a flight of stairs? Can they independently feed themselves? Can they do activities of daily living? All of which can be done by history. So the NIH stroke scale does require some interaction between the examiner and the patient. Where you may be limited in doing it is the visual field examination and the sensory exam. But most of the rest of the NIH stroke scale can be done through a video and can be done at, we'll say, 3 months or 6 months or a year after stroke. Robin, is that a good enough answer? All right, anything else we should talk about here? Somebody liked the lecture. That's always good to hear.
Okay. Last
well,
call for any other questions or comments.
I want to thank everybody for listening to me for the last hour. I also want to thank everybody for participating in this course, having been involved in it several times over the last few years. I think you all can have an opportunity to learn a great deal on the nitty-gritty way to organize a clinical research project, going from maybe, as we say, level 1 all the way up to maybe design of a large clinical trial. But don't be too grandiose in your plans. Start out simple. One of the phrases that has kept me well is KISS. Keep it simple, and you can put what the S is in there afterwards. So keep it, all right. All right, friends, you all have a good rest of the day. I'll hang up.
Okay,
Thank
you, Dr. Adams. And I just want to remind everyone to evaluate the webinar. The link is in the chat. And our next webinar is on June 14th. So just keep an eye out for an email coming out this week on that. So thank you everyone for joining.